Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor, Ardelyx, for their support of this podcast.
Welcome to the podcast. We're going to talk about IBS constipation and different therapies that are available and how we help patients understand these therapies. And there are simple over-the-counter drugs, there are prescription medications, and really the goal is to match the treatment to patients' specific symptoms. And, we'll talk a little bit about how we do that. So I'm Gabriella McCarty. I'm a nurse practitioner. I have been in private practice for the past 26 years, general GI, IBD, and hepatology. And I am making the transition over to OSHI, which is GI telehealth. And I'm here with my good friend, Kimberly Orleck. She's a PA. You can introduce yourself.
Thanks, Gabby. Hey, everybody. So I'm Kim Orleck. I'm a physician assistant practicing for 16 plus years out of Atlanta, Georgia, Atlanta Gastroenterology Associates, and really happy to be here with Gabby and to talk about IBS therapies today.
Yeah. So I think a lot of things are, talking about getting a good history with your patients. Like, is their main symptom bloating? Is it that they're not having bowel movements for several days and then they have a blowout? Is it overflow diarrhea symptoms? So just getting to the root of that specific patient, because as we talk about, it's not black and white.
Not one size fits all. It's not. Yep. I think the other important part, you mentioned a good history, right? And when I think about the therapies, and we're lucky now, right? We don't just have one option anymore, but I think it's important, even though we have multiple prescription options, it's really important that we think about there are some over-the-counters. But while some over-the-counter therapies and even things like fiber have some good efficacy, it's important when we think about these IBS-C patients that they don't just have the bowel issues, as you just alluded to, right? They have the pain, they have the bloating. And while a lot of these over-the-counter therapies might really help with their constipation, they don't necessarily help with that pain, with that visceral hypersensitivity that we've talked about before, and with these global symptoms like bloating, right? And that's one of the reasons, I love the prescription options we have, right? And I explain to my patients, I know we'll dig into kind of how do they work and how do we talk to patients about this, but I think one of the biggest things I love to be able to tell patients is this therapy we're going to talk about, it doesn't just address the bowels, right? We know it works towards that visceral hypersensitivity, aka that pain, and also those global symptoms like that bloating, which is very different than our over-the-counter options.
Yeah, and I agree completely with you. And being in GI, most of the patients that we see have tried every therapy. So they've been on fiber supplements, they've tried over-the-counter laxatives, they've been on stimulant laxatives. So just letting patients know, first off, that this is so common and that they're not crazy and that there are different options available.
And I think that's the biggest thing, because how often do you hear from patients, like, I was told there was nothing else, right? Like, try that PEG again and try the fiber again, or try that stimulant again. Or, hey, I heard from a friend about the herbal tea because nobody ever told me that there was anything else I could do. So I'm searching for all these natural remedies that I can find, because nobody mentions that there's prescription options.
And you would not believe how many things that people order off of Amazon.
Yep.
I'm just like, what are you trying to look this up? What is even in this? But it's pretty crazy. So we talk about osmotic laxatives all the time.
Yeah.
And that's a great option, but although patients might go to the bathroom a little more often, it's doing nothing for the bloating and the abdominal pain and those symptoms.
So I think we're lucky, right? The way I kind of break it down to patients is we all are familiar with our secretagogues, right? And so we know multiple of the options we have are secretagogues, aka they work to secrete fluid into the intestine. And we know that that helps to make the bowel softer, easier to go, increase motility, right? And we don't understand the exact mechanism, but we do also know that those therapies help with pain, right? And they help with the abdominal symptoms. Then we also have the retenagogue, right? And so I do try and explain to my patients, while the secretagogues, again, are kind of secreting fluid into the colon and doing all the things I just mentioned. And then we have a retenagogue where it's important we're taking it with food because it blocks the absorption of sodium. It actually keeps that sodium in the lumen. And so it helps to bring in fluid and then also help accelerate that transit time and that softness of the stool. And again, we also see benefit with that pain and bloating. So I think it's important that, I don't know that patients really want to know the GCC agonist and the deep down that we know, but I think it's important that they do have kind of the general take of how these secretagogues and retenagogues work. And again, why we're talking about those, because it can treat all of their symptoms. And I'm curious, I don't know, like, do you talk to your patients about the same way that they have a lot of symptoms? There's a lot of underlying pathophysiology, right? As you alluded to, driving their disease. And so I'm curious, I always have that conversation with my patients of the same way that not one thing is driving IBS. We're trying to use therapies that aren't just fixing one thing, right? They're kind of fixing multiple different pathophysiology entities that are driving your disease.
Right. Yeah, I have that same conversation. These patients too, they're so used to having these symptoms for a long time. So when we're starting new therapies, diarrhea
I know where you're going.
Yes. So it's important to really make them aware that this might happen, usually within the first few days, the first week. Sometimes I actually do a mini clean out, like a mag citrate the night before you start this. So you're kind of starting at a clean slate, and it makes the diarrhea symptoms maybe not so bad.
Yep.
But patients are not used to having diarrhea.
Yep.
So you really have to gather good information, because is this, okay, now you're having 2 loose stools a day and you're more fully evacuating, and you have not been used, you're used to not having anything for 4 or 5 days. So just,
setting
that this is
right?
normal. And to just stick with it. And they do tend to work fairly quickly within days to weeks.
Yep.
And, some of these therapies have different dosing regimens too. So you can kind of play around with that. But it's great to have multiple tools in the toolbox for IBS for sure. And
I think you hit on a really important part, right? Is number one, that we're warning about that diarrhea. Obviously, with some of our therapies like lubiprostone, I also talk to the patients, just we might see less diarrhea, but hey, you got to take it with food, right? You might see some nausea. So I think big summary of this is, while these therapies are great, we want to make sure we educate our patients on the potential side effects that they might have. I agree with you. I empty out patients a lot with a colon prep, particularly the really constipated patients, that the diarrhea is not so bad, but also setting the stage of, this is likely going to happen. I explain to them, like, you're backed up. We know it. You're constipated. When we give you something to take, it's very often those first day or days going to flush you. And that, even if it's not diarrhea that lasts to us, it feels like diarrhea to these patients who have been constipated for so long. Again, I warn them about nausea if it's more of lubiprostone. And then I know you hit on this, but I think the other part that's really important is we want to really set the stage for the patients of, when am I going to feel better, right? Because if we're fortunate enough to get samples or they pick up that first prescription, we want them to understand that while these therapies work great, it's not a magic overnight solution for all of their symptoms. I know I usually tell the patients, like, hey, your bowels typically get better faster, right? And I have that conversation again. I'm fortunate with samples usually of, here's a week, you should see max bowel improvement at that time. But to your point, a lot of these patients, it's the bloating and the pain that's driving it. And so making sure they understand that while that might improve, and very often improves in days to a week, it can take, right, up to 6, 7, 8 weeks.
6 to 8 weeks for, full effect is what I tell patients. So, I try to follow up in the office in about anywhere from 6 weeks to 3 months. It just depends on our schedules at the time, but always to schedule that follow-up visit no matter what, so that you can sit down and see if this is working. Do we need to try a different class? And just setting those expectations and being honest with patients and which medication will help the bloating potentially as well.
Well, thanks, Gabby. It's always fun chatting with you. I hope this podcast was enjoyable and helpful for everybody. And for more podcasts and educational information, please make sure to check out the GAP website as well as the GAP ACE app.